and all. I thank IAP for giving me the opportunity, and I thank Dr. Tirumurugan for calling me over. NRP is something very close to my heart. So we kind of take NRP to the students very passionately. So I'm very happy to do this topic on this CME day. So my topic is a little rarity. Maybe like I used to take some rare conditions. So I was given algorithm beyond positive pressure ventilation on advanced NRP. So how I'm going to take is my slides moving.
It's not moving.
Yeah. It's not moving.
1 second. I'll stop share and again share again.
So choose the window alone instead of entire screen otherwise. It's moving.
Yeah, it's moving.
So my objective would be to cover few things beyond positive pressure ventilation, namely intubation, alternate airway, chest compression, and medication, and also cover some of the special circumstances on a case scenario based on preterm, difficult resuscitation, and pneumothorax. And on and off, I would include some of the NRP addendum, which was laid down by IAP in NRP together, which is suiting for our Indian scenario. So this part has already been covered beautifully by my colleagues, Dr. Balakrishnan and Dr. Vinod. And again, a part of this book is covered. So I am going to cover on intubation, chest compression, and medication. And we just need to remember that all the time the assessment would include two components, namely heart rate and breathing. And also, since we have connected the pulse oximetry at this stage, it would include also saturation at all the points of assessments. So the first thing is about endotracheal intubation. So this is a skill to be learned. So what are the indications for endotracheal intubation? It is to improve ventilation efficacy. If positive pressure ventilation is with the face mask, does not result in clinical improvement. And also to improve the efficacy and ease of assisted ventilation if PPV lasts for more than a few minutes, and also to improve the efficacy of chest compression. So some of the special indications would include a suspected or a confirmed congenital diaphragmatic hernia, where we will not be giving positive pressure ventilation through bag and mask, but we will be going directly to intubating the baby. And also for direct suctioning, if airway is obstructed with excretion as a part of A in MR SOPA. So I insist that even in a non-vigorous meconium strained like a baby, there is no need for direct suctioning at the first point. We have to do it at a later stage if we find no chest rise in spite of MR SOP, in spite of doing even increasing pressure, we are not getting a chest rise. That time we can intubate. And also to administer epinephrine if umbilical venous access is being delayed. But of late, like we are insisting that umbilical venous access medication would work better than doing through endotracheal tube. So a person experienced in ET should be available to assist in every delivery. What is the mechanism? It improves the efficacy of ventilating the lungs. And Dr. Vinod has already told that what are the equipments needed for endotracheal intubation as well. And this is some of the charts which we can use for as a resources. These are the endotracheal size according to the weight and gestation age. This can be hung in the labor room so that like we have a ready-made available resources. And also these are the suction catheters for corresponding endotracheal tubes. So if it is a 2.5, we use a 5 suction catheter, and for 3 it is 6, and for 3.5 it is 8. But to know the anatomy, we want to intubate and we want the endotracheal tube to lie somewhere between from the cricoid cartilage here to the carina. So positioning the infant is very important before one intubate. So it should be in a sniffing position so that the line is very clear. And if the baby is too extended or too flexed, we will not get the line. So the steps would include preparation for insertion and also inserting the laryngoscope, lifting the plate. If this step is very important, many when they learn, they kind of rock, but the correct way of intubating is not to rock, but to lift the laryngoscope and visualize the landmarks. If you see here, this is the epiglottis and this is the vocal cord, the V-shaped vocal cord. So this is where the endotracheal tube is going to be placed. Where sometimes the assistant could give a right pressure to facilitate intubation and suction if necessary for visualization. Then the tube is inserted with the help of the right hand and laryngoscope is removed. I want to insist that someone should time from the beginning of intubation till the end. It should not cross 30 seconds. So this is a very important step. We should not allow the baby to go bradycardic. In case if we are not able to intubate, we should not have a fixation that we need to intubate. Rather, again, go back to bag and mask and then try intubation at a later stage. After intubation, assistant would be checking the position, checking whether the tube is in correct position by auscultating on the axilla on both the sides and also on the stomach. And as I said, after intubation, the trachea should be located below the vocal cords and somewhere above the carina. For that, we need to fix it. There are various methods of fixing, but in the recent 7th edition, they have told about this NTL, which is nasal septum to ear tragus. So it is from the middle of the nasal septum to the ear tragus. You measure this after intubating, and NTL plus 1 centimeter would be the fixing. It should be the length with which we should fix. So if we have to fix, there are other methods for measuring the length to lip. So this is a chart which is available in the NRP edition, which one could use to fix the 80. Say, for example, if it is a 27 to 29 weeker, 80 length at lip would be 6.5 centimeter. So the lip as represented here is whatever is. This is between 9 to 10. So this 9.5 is the lip level. So it is very important step to fix the ET tube. Once we know that this is the length to be fixed, when to extubate. So what we would recommend is, unless the breathing efforts are absolutely good, one could shift the baby to the NICU and consider extubating after stabilization. In case the baby has good spontaneous efforts and the heart rate is picking up and the heart rate is more than 100, that is an indication for extubation. But sometimes we consider the baby to be shifted in spite of having some respiratory effort to shift the baby to NICU before extubating. If there is any sudden deterioration, all of us know that DOPE has to be carried out. DOPE stands for displacement of ET tube, obstruction, pneumothorax, and equipment failure. The equipment failure can be as simple as the bag not working in case of bag and tube ventilation. So that completes the endotracheal intubation. So we are moving on to chest compression. So I am going to go through some indication mechanism, skill, and when to stop. Indication: if the heart rate remains less than 60 per minute, despite 30 seconds of effective positive pressure ventilation. But one could consider effective positive pressure ventilation as 30 seconds of PPV after intubation also. So if you notice, this is a clip which I have put from the NRP book. So in chest compression, even the chapter of intubation comes before chest compression. So what it says is, in most cases, you should have given at least 30 seconds of ventilation through a properly inserted endotracheal tube. So we often do not use laryngeal mask. So 30 seconds after insertion of endotracheal tube is when we consider, if the heart rate remains less than 60, we consider chest compression. What is the mechanism? It is because the cardiac function is depressed and you want to improve the coronary artery blood flow, which is very crucial. During the compression, there will be forward flow and increase in the pressure in the aorta. And during the relaxation phase, the heart refills with blood and blood flows into the coronary arteries. This is only a very crucial step. It is not a mechanical forward flow. It improves the coronary perfusion. So by compressing the chest and ventilating the lungs, one would help to restore the flow of oxygenated blood to the heart muscles. So as I said, if you would consider when the heart rate is below 60, and if we have to intubate, there are other steps which need to be done. If not intubated, intubate. Where during chest compression, it has to be coordinated with positive pressure ventilation. And also at that point, we need to start on 100% oxygen and also connect ECG monitor. So at this point, it is crucial for us to know what is the heart rate. So it is important if one has the facility to connect the ECG monitor, to connect ECG monitor at this point, if not connected already. So we need two people. So one person compresses the chest and one person continues the ventilation. And so regarding the skill, so where should we position the thumb? So it should compress the sternum in the lower 1/3. So the finger also should be supported back. So one can kind of imagine one finger breadth below the nipple line. So somewhere in the lower 1/3 of the sternum, and also apply pressure on the sternum and also release it so that you have a chest recoil and ventilation. Carefully observe here, there is some flexion of the proximal interphalangeal joint. This is a very important step. So when we are applying pressure, there should be some flexion of the proximal interphalangeal, and the pressure should be vertically down, should not be on the ribs. And also how much to compress. This is also important. Unlike adults, where it is done a little more superficially, in newborn baby, it is done 1/3 of the depth of the entire AP depth. And how to do, it should be in a coordinated cadence, that the chest person who is doing chest compression would be saying 1 and 2 and 3 and breathe, and 1 and 2 and 3 and breathe. So so there will be 3 chest compression for 1 ventilation. So there will be almost 120 events per minute, which happens in a cyclical fashion. So is there any alternate ratio? Because PALS, APLS, like most of the pediatrician would know that it is 15:2. But according to NRP, if a newborn has cardiopulmonary arrest within the hospital during this period, the NRP recommends using 3:1 compression to ventilation ratio unless there is a reason to suspect a primary cardiac etiology. So whenever there is a primary cardiac etiology, one should restore to 15:2. Otherwise, this 3:1 has to be stuck on. So what if the heart rate remains less than 60? So maybe your ventilation is not adequate, or maybe it is a time to move to the next step, namely medication. So the complication would include laceration of the liver and sometimes broken ribs. But if we do the technique correctly, these 2 complications can be avoided. When to stop chest compression? If the heart rate increases more than 60, that is the time when we need to stop chest compression. So next we are moving on to medication. So medication I will put here as epinephrine alone as medication. Purposely I did not in the title I did not put normal saline, because normal saline warrants assessment of for volume, and only if the volume is depleted we need to give normal saline. So, so indication would be 30 seconds of PPV. That means 30 seconds of PPV after the intubation, followed by 60 seconds of coordinated chest compression and ventilation. This is one have to consider epinephrine. So if you see here, if the heart rate remains below 60 in spite of your coordinated chest compression and PPV, and you have given 100% oxygen, that is when you will be giving IV epinephrine. What is the mechanism? It causes constriction of the blood vessels outside of the heart, which increases blood flow into the coronary arteries, again restoring the cardiac function. There is one more mechanism. It increases the rate and strength of cardiac contraction. So the preferred route is the IV access. We have to do with the umbilical catheter, insert only 2 to 4 centimeters where we see a flashback, less depth in preterm babies. And the equipments needed would include epinephrine. Now it is for us, it is available only as 1 in 1,000, which has to be diluted with 9 ml of normal saline to make it as 1 in 10,000. And it can be given through umbilical venous or sometimes through endotracheal. So if it is through umbilical venous, the dose will be 0.1 to 0.3 ml per kg, and if it is through endotracheal, it would be 0.5 to 1 ml. So when can we repeat? We can repeat as frequently as every 3 to 5 minutes. Any other alternate route, intraosseous, more likely in an outpatient setting. So how do we know whether there is a response? If there is a poor response, check the ventilation, check your efficacy of chest compression. Do not stop chest compression while giving medication. If not intubated, intubate and make sure that the epinephrine delivery is going into the umbilical venous line, and also consider hypovolemia. So this is a systematic review where they compared between endotracheal and IV epinephrine. Though in animal studies, there is not much of certainty. Indirect evidence from human studies, there is not much of certainty. From animal studies, they have proven that 0.01 to 0.03 milligram per kg dose of IV works better. So whenever there is a poor response to ventilation, you have to consider hypovolemia as well. So as such, it is not mandatory that all asphyxiated babies should receive bolus. What is important is it is indicated only if the baby is not responding to the steps of resuscitation and has signs of shock or a history of acute blood loss. It is very important. In an asphyxiated baby, do not keep on giving volume bolus without assessment of signs of shock. Only if there are signs of shock, one has to give IV bolus. So normal saline only is indicated. Previously, we used to say as normal saline or ringer lactate, but now there is no ringer lactate, it is only normal saline. In case of suspected anemia, uncross-matched low negative packed cells can be given. Can be given as intravenous or intraosseous. Use a 30 or 60 ml syringe and give 10 ml per kg of an estimated weight and give over 5 to 10 minutes. So what is the expected response? If the heart rate increases, pulse becomes stronger and pallor lessens, and if the blood pressure increases, one would consider that there is a response to volume expansion. So next is preterm case scenario. So this is a primary mother with severe preeclampsia, singleton pregnancy, 30 weeks of gestation, and antenatal scan showing fetal growth restriction without Doppler changes, and was taken as emergency LSCS. Was identified as high risk, and team briefing was done, and parents were counseled. During preparation, and already my colleagues have insisted that we need to increase the delivery room temperature. One has to use a preheat servo-controlled radiant warmer with temperature sensor. And if warming pad is available, we can use warming pad. Hat for the head is a very simple mechanism to improve your temperature regulation. And also use a polythene bag if the babies are less than 32 weeks of gestation. And also pulse oximetry, blender and TPs and CPAP. So this is very important. So you do not want hypoxia and we do not want hyperoxia and free radical injury. So this blender equipment is very important. And if the babies are born less than 35 weeks, we need to start positive pressure ventilation between 21 to 30% FiO2. So additional equipment would be needed in terms of preterm size mask and pre-warm transport incubator. And we are going back to the preterm scenario. Baby is delivered on assessment found to have spontaneous breathing. So delayed part clamping was performed. Warmth was maintained, and because the plastic wrap without drying under radiant warmer, hat was also placed. So pulse oximetry was placed in the right hand and also connected with thermistor skin probe from the warmer. Baby has labored breathing, mild retraction, but the heart rate remained more than 100. So the ideal measure now has to be done is the initiating delivery room CPAP. And also baby was transported to NICU in a pre-warm transport incubator. that ends the scenario. So this is how a CPAP would be started, and this is a plastic wrap to maintain the temperature with hat. Again, we have to follow the same targeted preductal saturation after birth as term neonate, because we do not have any separate chart for preterm neonates. So one has to take care of additional to reduce to decrease the brain injury. We need to avoid Trendelenburg position, and you have to adjust ventilation, avoid rapid intravenous fluid or hypertonic solution, and handle the baby very gently. So again, delayed cord clamping has been proven beyond doubt in a vigorous preterm neonate also. So you have to do for 30 to 60 seconds. So this is summarizing the what we would be doing in a preterm neonate. So anything in NRP addendum, whether to resuscitate or not resuscitate in a peri-viable period, would depend on the family wishes, and also the ethical issue, accuracy of gestational age, and whether the prognosis is certain or not, and also 1 unit's neonatal data. Based on that, we can decide whether to resuscitate a peri-viable baby or not. Coming to special circumstances, so this is a low risk, good progression of labor, unexpectedly floppy. So mother was not given any analgesics. Initial steps were followed by bag and mask. Baby remained apneic, and baby was intubated but needed a very low pressure. Such situation can happen. Baby for some reason would not breathe at all. So what are the reasons why baby will not breathe at all? It would include HIE, severe HIE, severe acidosis or congenital neuromuscular disorder, and also sedation secondary to maternal drugs. So this is one more baby who is a low risk baby. Baby was shifted to warmer, cried at birth, turned blue again. Then initial steps was done, baby cried again, then again becoming sinused. So whenever the baby is crying louder, the baby is having good efforts, but when the baby is calming down, baby is becoming sinused. So this is more, one has to suspect that at this point, we have to pass NG tube through both the nostrils to clinch the diagnosis of choanal atresia, because simply placing an oral airway would be a solution rather than giving bag and mask or doing intubation for this particular neonate. Again, one more scenario. This baby had polyhydramnios, antenatally polyhydramnios, and baby after delivery, baby had noisy breathing with suprasternal retraction and had micrognathia. So whenever there is a micrognathia, a simple maneuver which will change the scenario would be to put the baby on prone positioning. And whenever there is a difficulty in resuscitation, call for help. If the baby is bradycardic, go for an airway or nasal, oral or nasal airway insertion. Intubation would be difficult in these babies because tongue would interfere. Videolaryngoscope can help, or LMA would help. If it is antenatally detected, one could consider exit therapy. So this is some of the pictures of micrognathic babies. So if you see here in this line diagram, the tongue is falling back and like there is no airway at all. So once you put in prone position, the tongue will fall forward. So you can use oral airway or indigenous method to preserve the airway. You can use LMA also if your unit has one. This LMA will go and fix, get inserted in the laryngeal inlet. So one more last scenario. Baby was called for resuscitation for meconium Steinleicher, not cried at birth and non-vigorous. We know that there is no role of intubation at birth in spite of being non-vigorous. And if there is no chest rise in spite of MR SOP, that time one would use the meconium aspirator and suction out. So if no meconium is recovered, proceed for resuscitation. If meconium is recovered, you can check the heart rate. And if the baby is breathing well, then you can proceed. So one can suspect pneumothorax if there is no response. Other causes for babies who will not be responding for your normal resuscitation would include pleural effusion and congenital diaphragmatic hernia. Other causes will be critical congenital heart disease or persistent bradycardia due to heart block. So with that, like one last, I want to touch upon this, when to stop resuscitation. Whenever you have non-detectable heart rate, that means heart rate is 0 at 10 minutes, it is reasonable to stop. They are not recommending you to stop all the time. It is reasonable to stop, and the decision has to be individualized. So to summarize, the requirement of chest compression or medication, as insisted by my previous speakers, were quite uncommon. Effective ventilation is the key in NRP. In preterm, first do no harm. Use delivery room CPAP with blender. Thermoregulation will be important. Anyone can face unexpected situation during resuscitation. So your knowledge on these situations would help. Thank you.
Thank you, Dr. Uma Maheshwari, for your excellent presentation on advanced NRP. And now we move on to the next slot. I will ask Dr. Prakash to have a video demonstration of the advanced NRP. Over to Dr. Prakash.
Thank you very much for giving me an opportunity on this topic. In fact, we did prepare a video for one of our NRP sessions. So we thought we'll run that. That will be more of a scenario like this thing. Actually, I liked the video of Dr. Vinod, who actually has put up in a very nice way. Probably I have done it in a different way.
We are not able to hear Dr. Prakash. We are not able to hear you.
1 minute.
Your voice is less.
Okay. Yeah.
Your voice is less. Just increase the tone.
Is it better now? Is it better now?
It's okay.
Hello, is it better now? Still low?
Still low.
Okay. 1 minute, let me check on that.
Dr. Prakash,
It's clear now.
hello?
Okay. Is it clear? Is it audible now?
Yes, sir.
Audibility less. Now better.
Now it's better.
Yeah. If you can increase it further, it will be great.
No, actually, I can't increase the volume. I can only change the setting.
This is better. This is better than before.
Okay. Okay. Fine. Okay. So I'm just I've been given the task of showing a video demonstration of resuscitation beyond. Sorry.
Your voice is not very clear. Maybe you can speak near the.
Okay, fine. So I'll do one thing. I'll go to the other.
Can you hear me now?
Can you hear me now?
Yes.
Is it better?
Is it better?
It is okay, Prakash. You go ahead.
Okay, sir. Please proceed.
Okay.
So there's the video
I'm going to demonstrate on
resuscitation beyond resuscitation. So if you're going to start with
this is a case scenario where there is a priming
mother where delivered at 38 weeks and the baby was floppy at birth, was baby has been provided with the initial steps of ventilation, initial steps of resuscitation, followed by PPV, and then for 30 seconds, and then followed by
Prakash, if you are using 2 sets, then the echo is constantly coming. Please
okay
do
now?
1 step. There is
So this is the scenario where we are actually dealing with a baby who's been given initial steps and then 30 seconds of effective ventilation, after which we are going to assess the baby's breathing. When the baby is not breathing and the heart rate is less than 60, and which is actually the actual heart rate is 40. So this video will start from that. So if you look at the video, and then we're going to start.
Let us 30 seconds.
Is the video sound audible?
Breathe 2, 3. Breathe 2, 3. Breathe 2, 3. Breathe 2, 3.
Dr. Shafi sir is on the way.
Breathe 2, 3. Breathe 2,
Thank
3.
you. Thank
Breathe
you,
2, 3.
Surya.
Breathe 2, 3. Breathe 2,
Okay,
3.
now at the end of
Breathe
30
2, 3.
seconds,
Breathe 2, 3.
now they are
Breathe
assessing
2,
for
3.
the heart
Breathe
rate.
2, 3.
So they
Breathe
can
2, 3.
Seconds over, sir.
Breathe 2,
video
3.
is not
Let me check the heart rate.
Breathe 2, 3.
Oh,
Breathe
okay,
2,
sorry,
3.
sorry, 1 minute.
Breathe
Dr.
2,
Prakash
3.
video வரல.
Breathe 2.
Disturbance.
Okay,
ரொம்ப disturbance கேட்கல.
yeah, 1 minute, sir.
But video is not playing.
2-3 வாய்ஸ் வருதுங்க மிஸ்டர் பிரகாஷ்.
Yes, sir, I understand that. Just give me a
ஒன்னும்
little
பிரச்சனை
bit
இல்லை.
of time. I'm just rectifying it, sir. Just a minute.
Yeah, no problem.
Yeah.
Yeah, you can maybe restart the video if it's
Yeah.
okay with you.
So this video is going to start. Can you hear me now?
Yeah.
Okay, ma.
This video is going to start now with your with after PPV. They are going to ask us for the breathing and the
Breathe
heart
2,
rate.
3. Breathe 2, 3.
So-
Breathe 2, 3. Breathe 2, 3. Breathe 2, 3.
seconds over, sir.
Breathe
So
2,
at the end of
3.
30
Let me
Breathe
check
2,
the heart rate.
Breathe 2,
Dinesh.
3. Breathe 2, 3. Breathe 2, 3.
For breathing
Breathe
and
2,
heart
3.
rate.
Breathe 2, 3.
So
Breathe
we have
2,
not
3.
connected ECG.
Breathe 2,
If you had an
3.
ECG,
Breathe 2,
probably you
3.
can use ECG.
Breathe 2, 3.
Because
Breathe
it's not
2, 3.
connected, we are going to
Breathe
go
2,
Heart
3.
rate is only 4
Breathe
in 6 seconds.
Breathe
That is
to
40
three.
per minute.
Breathe 2, 3.
So the heart rate
Breathe
is
two,
Let's
40.
go for chest
Breathe
compressions
2, 3.
now.
Breathe. Yes, sir. We'll
Before that, we'll
intubate.
prepare for intubation also.
Yes, sir. We'll intubate the baby, sir. Holding the laryngoscope on the left hand and holding the
As a first
ET
step
tube on
of
the
when you
right
start
side,
your
right
chest
hand.
compression, you have to actually intubate because that will give you effective ventilation. And also your coordination will be less with the positive pressure ventilation with the bag and mask.
And irrespective of the handedness, inserting the laryngoscope.
Is the video audio? Can you hear the audio of the video? Is the video audio is audible?
Yes, sir. From the right corner of the mouth and towards the left side of the
So first the intubating.
baby. What we are seeing the
Going to
structure
right
is
side of the mouth.
esophagus. To visualize the vocal cord, pull out the laryngoscope little until visualize the vocal cord. If you are seeing,
So what you see now is the epiglottis. So first what you saw is esophagus. As you pull out, you should see the vocal cords. If you're seeing the epiglottis, that means you're too much out. In that case, you need to go in again to visualize the vocal cords. So that's what is going to happen now. So now we're going to go there. A little bit of required pressure is
epiglottis
given.
and the base of the
And then you can see
and lift the tongue,
this thing has
and
been
you can see
the
you can
V-shaped
visualize
vocal
the
cords there.
vocal cord. Once you visualize the V structure of the vocal cord, insert the ET
Don't
tube.
go through the laryngoscope blades
So
channel.
go to the laryngoscope.
Thank you, sir.
Always go from the side
Pointing
of the
out,
mouth.
and I'm inserting the ET tube from the right corner of the mouth.
Always go from the right corner of the mouth.
While inserting the ET tube, visualize the vocal cord and insert the ET tube to confirm the ET tube is going through the.
Dr. Dinesh, take care not to injure the upper gums, please.
Remember the
Yes, sir.
rest
Yes,
on the
sir.
upper.
I intubated the baby, sir.
Good, Dr. Dinesh.
I'm taking out the blade and unlock the laryngoscope.
It's good, Dr. Dinesh. You have intubated within 30 seconds. It's really good.
If you recollect, the intubation should be done within 30 seconds. So that is what has been done now. So
I'm holding the ET tube against the hard palate.
Dr. Dinesh, you continue positive pressure ventilation now.
Yes, sir. I'll continue positive pressure ventilation.
Please continue.
Breathe 2, 3. Breathe 2, 3.
I'll just
breathe
check the
2,
air
3.
entry for you.
Breathe 2, 3. Breathe
Chest
2,
is
3.
nicely rising.
Breathe 2, 3. Breathe 2, 3. Breathe 2, 3. Breathe 2, 3. Breathe 2, 3.
Fine.
Breathe
Air entry is equal bilaterally.
Breathe 3. Breathe 2, 3.
Now I'm going to measure NTL.
Breathe 2, 3. Breathe 2, 3.
Nasotracheal,
Breathe 2, 3. Breathe 2, 3.
from the middle of nasal septum to the tragus.
Breathe 2,
To know the depth of the incision of ATT.
breathe 2,
It is 8 centimeters now.
breathe 2, 3. Breathe 2, 3. So NTL plus 1, 9 centimeter. I'm fixing at 9 centimeters, sir.
Thank you, Dr.
Breathe 2,
Dinesh.
3. Breathe 2, 3.
I'll just secure the
Breathe 2, 3.
ATT now.
Breathe 2, 3. Breathe 2, 3.
Surya,
Breathe 2, 3.
can you
Breathe
please
2, 3. breathe 2,
Connect
3,
100% oxygen now.
breathe 2, 3,
Okay, sir.
breathe 2, 3, 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 breathe 2, 3.
Connected oxygen to the bag
Breathe 2, 3,
at a flow rate of
breathe
10
3,
liters per minute, sir.
breathe
Thank
2,
you.
3,
Let
breathe
me
2,
check
3,
the air entry bilaterally now.
breathe 2, 3, 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 breathe 2, 3.
Air entry is good bilaterally. We'll continue for 30 seconds.
Breathe 2, 3, 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 breathe
So
2,
if you see here, they are actually providing a positive pressure ventilation for for about 30 seconds. Okay, so you can see that it's been given, and then once you intubate also, they are giving for about 30 seconds. Okay, so on
breathe 2, 3, breathe 2,
Mr. Surya, please let us know at 30 seconds.
breathe
Okay,
2,
sir.
3, breathe 2, 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 3,
30 seconds over, sir.
breathe 2, 3,
Let me check the heart rate now.
breathe 2, 3, 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 breathe 2, 3.
The heart rate is still 40 only.
Breathe 2, 3.
To continue back and mass, I'll just start with chest compressions now.
Breathe 2, 3.
I have arrived. How can I help you?
Thanks, sir. Can you please prepare for the UVL access, sir, please?
Thank you.
So I'm just starting chest compressions now. I'm doing the thumb technique. I'm placing both my thumbs in the lower third of the sternum, below the imaginary line joining the nipple. Other fingers is encircling the baby's body, and avoiding injury to the cipit sternum. I'm just compressing the chest at the 2 and 3 and breathe in. 1 and 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 2 and 3 and breathe in. 3 and breathe in. 1 and 2 and 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 3 and breathe in.
I'm going to prepare umbilicus venous access in a sterile area. I have prepared a sterile area here.
So in the meantime, when you are doing your resuscitation, they already called for help when you started chest compression, and then we are going in for umbilical line preparation. So this is what is this video, and remember the background. They are doing a chest compression because you'll have time to actually do the chest compression. When you're doing the chest compression, along with it, you could do that.
I've got a
That's what
cannulation
is
tray with me.
demonstrated.
Mr. Surya, can you please give me umbilicus venous line of size 5?
That's the chest compression is going on. To make you
Give me
understand, we did
3-way cannula
so
and give me 5 ml syringe.
at the end of 1 minute, we need to reassess for the same thing, respiration, heart rate, and the saturation.
Give me
Actually not picking
normal
up,
saline.
it's still less than so we're continuing with chest compression. In the meantime, we are trying to prepare for IV access. And remember that
I'm going to
you
take
could
5
actually
ml of
possibly
normal saline.
you can actually possibly give
I have taken 5 ml normal
chest
saline.
compression.
Now I am going
give
to
an
flush
episode of
my umbilicus venous catheter.
give a dose of
Attach
this through the ET tube.
3-way cannula and then attach the catheter. Now I'm going to flush.
1 and 2 and 3 and breathe in. 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 1 and 2
And now I'm going to flush the
2 and 3 and breathe in.
catheter here. Now I'm ready with my umbilical catheter. Mr. Surya, can you please give me another 1 ml syringe, 3-way stopcock, and adrenaline, which is already prepared in the ml syringe.
1 and 2 and 3 and breathe in. 1 and 2 and 3 and breathe in. 1 and 2 and 3.
Now I am going to load
3 and breathe in. 1 and 2 and
1 ml
That
from the already prepared 1 in 10,000 adrenaline.
2 and 3 and breathe in. 1 and 2 and
I am going to take 1 ml of
3 and breathe in. 1 and
adrenaline from already prepared 10 ml of 1 in 10,000 dilution.
1 and 2 and 3
Now I have
and breathe in.
taken 1 ml now. Now I am going to attach to the
1 and 2 and 3 and breathe in.
stop cost
3 and
3-way. Now I am ready for the UV line insertion.
1 and 2 and 3 and breathe in.
1 and 2 and 3 and breathe and 1 and 2 and 3 and breathe and 1 and 2 and 3 and
I am ready with the preparation for umbilical line.
End of 1 minute, we're going to assess for the heart rate.
1 and 2 and 3 and
1 minute over, sir.
1 and 2 and
At
3
the end of 1
and
minute, we're going to assess
Let
for
me
the
check the heart rate.
We're going to assess for the heart rate.
Pulse oximeter is not picking up. So heart rate is 40. We need to go for drug administration EV as planned.
So we're
I'll
going
move
for
to
a
the
drug
head end of the
administration.
baby.
So you
as
could
to
see
give
there the the
access
portion
for
of the
you
chest
to
compression. We don't discontinue chest compression for
line
IV
access.
access.
I'll quickly
So we
clean
go
the
for
periumbilical area.
continue with the same
umbilicus.
2-thumb technique.
2 and 3 and breathe and
Okay, and then you go for the change your position to the head end. So that's also in this way also your intubation would be of great help, so that you can move position and do it.
2 and 3.
So you are
2 and 3 and breathe
I'll
and
put
head end, and now
umbilical line.
you could see that the umbilical line is being accessed.
2 and 3.
If this is only if the heart rate is less than 60. If the heart rate is more than 60, you just only continue only with positive pressure ventilation and stop chest
2
compression.
centimeters
So still less than 60, we are going for an IV access.
level.
1 and 2 and 3 and breathe and 1 and 2 and 3 and breathe and 1 and 2 and 3 and breathe and 1 and 2 and
I'm going to insert
breathe and 1 and 2
UV
and 3
line.
and breathe and 1 and 2 and
I'm
3 and
identifying the
2 and
umbilical vein, which is very
3 and breathe and 2 and 3
deep,
and breathe and 1 and
collapsible, and I'm inserting the UVL up to 4 centimeter, and yes, I am.
Consider the UVL and looking for a backflow of blood.
Yeah, I'm getting the
You could
backflow.
see that
I got the UV
backflow
access.
of blood. As soon as you get the backflow of blood, you stop there.
1 minute
You
over,
flush
sir.
the blood back, and then
Check for the
see the
heart.
three-way
There's no
valve which is
breathing
attached. So at the end of 1
Pulse
minute,
oximeter
again we are
not
going to
showing the-
reassess heart rate, because even with
not
this chest
picking up the
compression,
signal.
heart rate could have improved.
Heart rate is
So you could see that heart rate has been tapped on the side. It is showing about again
heart rate
40,
is 40.
and then so now we have decided to proceed with the drug administration.
Shafizah, can you please give? Baby appears to be 3 kg, so can you give 0.3 ml of adrenaline?
Yes,
So you're
I'm
starting with
going to give
0.1 ml per
0.3 ml
kg.
of adrenaline,
So 0.3 ml of
Followed
adrenaline
by
given, and then
normal
followed by
blood pressure
we are
of
taking a flush,
3 ml.
and then we are flushing it with
Now,
3 ml of saline.
Sister Surya, can you tell me when it is 1 minute?
And then we ask somebody to intimate when it is 1 minute. No, again the reassess becomes 1 minute. And remember, at the end of this 1 minute, we don't give adrenaline again. Here we again proceed with your chest compression.
1 and 2 and 3 and breathe and 1 and 2 and 3 and breathe and 1 and 2 and 3 and breathe and 2 and 3 and breathe and 1 and 2 and 3 and breathe and 2 and 3 and breathe and 1 and 2 and 3.
Okay, so this is your this thing now.
1 minute
This
over,
thing
sir.
started picking up.
So the pulse oximeter
oximeter.
started picking up the heart rate with a good pulse waveform. So the heart rate is 87, stopping the chest compression, continuing with positive pressure ventilation. Breathe 2, 3, 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 breathe 2, 3.
30 seconds over, sir.
So, assessment becomes 30 seconds from 1 minute, because only
positive pressure ventilation for some time. Let me
you
assess.
could see some breathing
There is
efforts.
some respiratory efforts.
So the breathing efforts coming
so
in.
the heart rate is
And
150.
we are going to again look assess the
and
heart rate and
saturation is
saturation.
95%.
So this thing is
95% at the end of 5 minutes.
so we have resuscitated
I
about
think
for
they
5
go the
minutes,
target
and now
range.
it is heart rate
You
is
start giving
117 and
positive
93
ventilation.
saturation,
And
for which we are happy
you
about
start
it.
reducing the oxygen. Now we are at 10 liters per minute.
So we are
So we're
just
going to
reducing the
reduce
oxygen
it to
delivery to the baby. Either you can,
5
if you have a
liters.
blender, you can reduce it through a blender. If
And
you do
with
not
the,
have a blender,
watch on
then
the
probably you can reduce the
saturation.
oxygen flow rate delivered
The saturation is
through the bag and
good.
mask. So that also will
Continuing with
reduce your
positive pressure
oxygen delivery to
ventilation.
the baby. And then we need to
Preparing to
shift
shift the
this baby
baby
to
to the
post-resuscitation
NICU
care.
for post-resuscitation care.
And remember, the most important thing which you have to maintain from here on is you need to maintain your, what is that called?
the temperature, it should not be, it should maintain euthermia and not hypothermic. It should not be hypothermic anytime. And then, you can, depending on the unit policy, you can proceed to, give whatever you would like to. Now, there's just a real-time video which actually you could, demonstrate how actually the chest compression has been helpful. This baby was on HFOV actually, and then you could see that the heart rate has become 0. We started providing chest compression. We have not yet given adrenaline because the first time it has just become like that. So you could see, the chest compression, you can see the arterial and this intra-arterial blood pressure. Then you can see intra-arterial, this is the SpO2, and with effective, chest compression, you could see that ECG waves are starting to come back. Now remember, we have not given adrenaline here. Okay, so at the end of 1 minute, so you could see, so this is one of the thing for you to know, really believe that chest compression helps in this baby. Right. So I hope the video demonstration was fine for everyone. Is there any other clarifications? Then I would like to proceed. Otherwise, this is about once you finish both. Then after beyond this, what you need to do is, if at all even after giving adrenaline does not improve, then we need to go for providing normal saline 10 ml per kg over 5 to 10 minutes, and then you need to reassess, and then after giving the final dose of about 0.3. So you start with 0.1 ml and then you increase it to 0.3 ml per kg. So next time you can give 0.2, and that is at the end of 3 minutes, and then you can give another another dose of 0.3. Even with that, you don't have a response, or with the first dose itself, you do not think there is adequate response, and there is a background history of an abruption or APH, then probably you can proceed to give volume earlier. So these are the two drugs which you need to remember, as to complete in short, which you need to say. And if do I have time, or is it the time is over? So then we can.
I think we are running short of time, Dr. Prakash.
Okay, right. Now, in that case, it's not a problem. I have a preterm video and also I see the insertion. So if the time is not there, then probably I'll finish up with this. Hope the presentation was fine.
Thank you, Prakash, for your nice video presentation. Now we'll move on to the next topic on Murugan. NRP 2020 guidelines. What is new? Before that, there is one question in the chat. Any one of the speakers can ask. How will you manage a case of macroplasia? There is one question in the chat. How will you manage a case of macroplasia? Arunachalam from Nagarkoil. Anybody?
Sir, good evening, sir. Good evening, sir. Dr. Uma here. Generally, like macroglasia, the tongue, unlike glossoptosis or micrognathia, where the tongue falls back, macroglasia may not lead on to obstruction. We could do a nasopharyngeal airway or nasopharyngeal intubation if tongue, like in the sense it is occupying the entire oral airway.
Just to add on to that, the other option would also be to consider laryngeal mask airway. It's not expensive these days. I think you can get about for 600 rupees, you can get one. So if you really come across a case like that, you could use that as well.
So now we move on to what is new in the new NRP guideline 2020. Over to Dr. Thirumurugan. Thiru?
Hello, can you hear me? Sir,
Yeah.
Okay, sorry.
Please share your.
Yeah. Okay. How often we wonder who decides these NRP guidelines? Okay, so every guidelines is decided by the body, isn't it? So who decides these NRP guidelines? And I think most of us, the impression is that we copy them from the West, particularly from the United States, because That's a book which we have seen right from the days when we started. Now, please remember that NRP has a program has changed from the time it has started about 20 odd years back, actually, when at least I started learning about 25 years back before that. And please remember the only constant is change, and it's up to us to not to resist change and to embrace it, because definitely this is one program which is so evidence-based, and it is based on this evidence, the program has developed to such, I mean, such wonderful program. So the neonatal registration program by itself, the guidelines are set up by a body called as the International Liaison Committee on Neonatal on Registration, the Neonatal Task Force, which is actually a body which has 13 countries representing this body. So those are the countries: the American Heart Association, the European Registration Council, and so on. So what basically they do is they collect all the data which has been published on neonatal registration over the past 5 years, and then they go through it in a very structured manner, and then decide on come out with the recommendations. The 7th edition of the the AAP neonatal registration book is based on the 2015 guidelines, and now in 2020 that has been adopted. They have come out with a new set of guidelines, which is still yet to be adopted. And I think by July 2021, American Academy of Pediatrics is going to come up with the 8th edition. And it's not just the American Academy of Pediatrics. Every country which has its own registration guidelines basically follow the recommendation from this ILCOR group. So I'm just going to go through what is pretty much been announced recently, and it's still not gone on to the registration program. Before that, I think we have had a wonderful session so far. I just thought I'll just run through and then do a bit of recap on the program itself and the algorithm. So basically, whenever we call in for registration, we have got 3 things to do. Start with antenatal counseling, find out who are the team members, have a team briefing, try to allocate their roles, their responsibilities, and do equipment check. By the time we do it, we have the baby is born. Now, when the baby is born, the questions we are going to ask is the baby is a term baby, is a good tone, and the baby is breathing or crying? And the answer is if yes to all those 3, and then all we have to do is leave the baby with the mother. Just don't jump in and then take the baby away from the mother. Deliver the baby onto the mother's abdomen. Keep the baby warm. If necessary, clear out the secretions and dry, and then just see what the baby is doing. If the baby is breathing and is okay, I don't think we need to necessarily take the baby out from the mother and then try to do things which are not necessary. However, if the baby is not crying, has got a poor tone and is just not breathing, then obviously we have to clamp the cord and then cut it and then take the baby away from the mother. Again, we need to warm the baby and maintain the normal temperature. Now, this is the time when we position the airway, clear secretions, dry and stimulate. And then you reassess at the end of 30 seconds. If the baby is apneic or is gasping, or if the heart rate is less than 100, then you go ahead and start positive pressure ventilation. And this is the time we need to consider using a SpO2 monitor, pulse oximeter, and consider using a ECG monitor. However, if the baby is not gasping, he's breathing, but then he's got significant distress, maybe he looks cyanosed, or maybe if the pulse oxygen saturation is less than what is appropriate for the minute of the life, which the guidelines which was given by Dr. Balakrishnan. In that case, we have to consider giving oxygen or CPAP if it's available. And then once the baby is stabilized, we shift the baby to post-resuscitate care. And never forget to debrief the team. See, more often than not, we have a tendency to scream at our team members when the procedure is going on, when we are resuscitating. But at the end of it, we never care to tell them what is right and what is wrong. So, suppose if after effective positive pressure ventilation, if the heart rate is still less than 100, what do we do? Then that's when we look at if we are giving effective ventilation, and take the corrective steps, MR SOPA. If necessary, this is the time you may consider intubating or using a laryngeal mask airway. And in spite of that, if the heart rate is less than 60, then start cardiac compressions and obviously do a synchronized PPV. I mean, we have gone away from asynchronous ventilation and cardiac compression. And at this time, we definitely use 100% oxygen and ECG monitor. And if the heart rate is still continues to be less than 60, then definitely use IV adrenaline and consider giving normal saline even after prolonged ventilation, and maybe consider pneumothorax. Now, this is pretty much what we have been taught so far and what we have discussed so far. Now, with regard to the guidelines changes, what has happened? So in 2015, our initial antenatal counseling and the team briefing consists of 4 questions. What is the gestational age? Is the amniotic fluid clear? How many babies? And what are the additional risk factors? Now 220, they removed basically the how many babies and then talked about umbilical cord management plan. Now one word on the umbilical cord management plan. Basically what we need is to have delayed cord clamping. Now how long you would delay? Now, minimum of 30 to 60 seconds. Even now, there are big questions about what happens if the baby is flat. Even in flat babies, we could consider. I mean, the research is more in terms of considering to delay at least for a few minutes so that there will be some amount of placental transfusion which happens. So, irrespective of status, definitely consider delaying the cord clamping. And this is something which we have to discuss. And not only that, we have to tell our obstetricians. Invariably, our obstetricians are very keen on clamping the cord soon after delivery. And that is something which we have to tell them. Now, the next thing which we would need to do is about our routine care, the initial steps. Now, in 2020 is what we have been told. Okay, basically we do a warm, take care of the airway, dry and stimulate, and then again reposition the airway. So what are WADA? Warm, airway, dry and stimulate, and then again reposition the airway. Now, but just think about what we do in real life. We never do it actually. When the baby comes, immediately we start wiping, we start drying. So, and then only we really position the airway. And this is the change which has been incorporated. They have become practical. They have said, fine, irrespective of what we teach, this is what is going to do. So, so it makes more sense just to accept and then start with warm, dry, at the same time drying causes stimulation, and then position your airway and clear secretion. Makes life very easy for all of us. Then the next thing is about meconium stain fluid. This is, I mean, again, Dr. Balakrishnan touched about. And what we need to remember is, this is not a guideline which has come in 2015. This is a 2010 guideline. And what they said this, maybe non-vigorous babies, you should consider intubating and then ventilating and then doing endotracheal section. But since then, that has totally been removed away, irrespective of whether it is a sick baby or a baby who is crying. Just don't bother to intubate the child to clear out the meconium from the trachea. What we need to do is clear out as much secretions as possible, whatever meconium is there, from the mouth and then the nose, and then start bag and mask, I mean, effective ventilation, whichever way you use it. Okay, so this is not something new, but unfortunately, even today, we find that people are still trying to intubate and try to do a meconium, suck out the meconium. There is only one indication. If you really think that the airway is blocked because of meconium or some particulate matter, then might be the only indication to intubate and to try to suck. Otherwise, it's not there. Okay. Now, again, way back in 2010, oxygen concentration, regarding oxygen concentration, there was a lot of controversy. And then people said, for term babies, you could try to titrate, whereas in the preterm, try to start on a higher concentration and then try to wean it off. And right now, I think it's very, very clear. Term babies just start only in air. Just don't bother about oxygen. Okay. Because the oxygen saturation for a neonate in the, I mean, for a baby in the in utero is only about 60 to 68%. So why are we just trying to boost it up to so high and cause a lot of oxygen-free radical injury? And for preterms, even less than 35 weeks, we need to start in anything, not more, anything less between 21 to 30%, and definitely not more than that. And our guidelines for giving more oxygen should be decided by our also oxygen saturation and not by, I mean, just like that, give them a huge amount, whack them with a huge amount of oxygen. The next thing is about something which we didn't talk about it because it's again gone on into disuse, but something which we have done it long time back is felt that sustained inflation, that is initial 5 breaths, what you do is you give back for at least 2 to 3 seconds. I mean, your inspiration would be for 2 to 3 seconds, and then allow the baby, and then allow for expiration. So the idea was for 5 sustained inflation breaths to have 2 effective breaths. That was the original idea. But now what has been told is definitely in preterms it is harmful and it's no point in trying to do sustained inflation. However, for term neonates, still there is not enough evidence whether it's useful or not useful. So they have not made any specific recommendation for term neonates. So if you are somebody who's comfortable using it, do it. But please remember that the pressure which we are delivering is very huge. It can cause significant pneumothorax and lung injury. Again, something which is coming up in a huge way just to deliver CPAP in the delivery room. So 2010 guidelines didn't talk about it, but since then it has come in. And right now, any baby who has got spontaneously breathing with respiratory distress, use CPAP. And the best way to deliver CPAP in a delivery room, it would be to use a TP resuscitator with which allows us to deliver a PEEP. And sorry, the CPAP. And in 2015, what they said was that electronic cardiac monitor is the preferred method for assessing heart rate during cardiac compression. So we are no longer looking at interrupting our resuscitation with auscultation, or we're looking for umbilical arterial pulsations. But 220 guidelines, they made it very clear that even whenever you need an alternative airway, and just not wait till you are going to have cardiac compression. The moment we try to intubate, the moment you try to put a laryngeal mask airway, go ahead and then connect the baby to a ECG monitor. And because this gives us the most accurate measurement of the heart rate. And what is the best way to do? I think we have forgotten the 2-finger technique a long time back, 2010. I just want to reiterate, and that's why I just put it in. So the best way to to give cardiac compression is definitely the Preterm technique and not the 2-finger technique. And there was this question about what is the exact dose of adrenaline to use. Okay, in 2015 we still had a range 0.1 to 0.3 ml per kg of 1 in 10,000 solution, and for endotracheal it is 0.5 to 1 ml per kg. Now it has been changed. It's 0.2 ml per kg for intravenous or intraosseous route, and endotracheal you could use it only once, maybe while we are trying to get a venous access, and that would be 1 ml per kg. And what would you do after giving the drug? For intravenous route, you could always use a flush of 0.5 to 1 ml of normal saline, whereas in the 2020 guidelines, it is 3 ml of normal saline to be given as a bolus after giving adrenaline, either in the intravenous or a intraosseous route, and definitely not for endotracheal route. Now, this was something which Dr. Uma spoke about, that if after 10 minutes of resuscitation, if there is no heart rate, we could consider stopping it. But now the evidence has moved from 10 to 20 minutes. Now they say that, and even at 20 minutes, you consider cessation of respiratory effort, resuscitation effort, and not just discontinue it. Okay, so that definitely the time has gone longer. And those are the important recommendations, which all of them which make sense. But let me start with what let me conclude with what I started with initially in the first presentation. We should all consider having some sort of recertification or training every 2 years. Indian Academy of Pediatrics, along with is doing 2 types of program. One is for the basic NRP, which is for everybody who is involved in newborn care. That could be your staff nurse, it could be a nursing assistant, it could be you. It could be anybody, it doesn't matter. Okay, and then it is, and they, in fact, they are coming up with the second edition. So far, we are using the first edition. Now it is coming up with the second edition. And now there is the advanced NRP, which IAP is actually considering doing it free. Even for previously, we are paying about 4,000 rupees. Now that is being done free for life members of IAP. I think we should undergo one of those at least every 2 to 3 years. Now, just to conclude without taking more messages, basic NRP is for low-risk newborns who are going to be managed in the peripheries. Advanced NRP is for high-risk newborns. The key to successful resuscitation is all about anticipation and preparation. I mean, Dr. Prakash shows in those wonderful videos how well they are prepared. And I think that is something which we should adopt at all places. Ultimately, it's all about effective ventilation. and it is the most important step in any neonatal resuscitation. Okay, it's not cardiac compression, it's not adrenaline, it's not bicarb, it's definitely not normal saline. Okay, please remember that advanced resuscitation measures such as cardiac compression medication is rarely needed. So if you have attended 7,000 deliveries, you probably would have done it once. So I think for most of us, it's a matter of maybe 4 or 5 times in our lifetime. So think about it and then try to concentrate on ventilation. Thank you very much for your patient listening. Thank you.
Thank you, Dr. Thiru, for your excellent presentation. Before I am addressing to the chat box, I just put a question to Dr. Thiru. I think, to my knowledge, the 7th edition, we are using it till December 2021. Am I correct?
So actually no, so they said 2022 also. So for after 1 year after they are published, they are going to use, which means till 2022 we are going to use it.
The 8th edition is going to come on June 2021, but implemented by January 2022.
Yes, sir.
All the changes you have already mentioned in the 7th and the 8th edition also. So I congratulate all the 5 speakers for their excellent presentation. And there is, let me see the chat box. Why it is not time?
So there's one question.
Yeah, please, Dr. Ramachandran has asked. 1 minute. Is there any Indian committee of resuscitation?
No, sir, there is not any Indian committee as of now. What they have is actually the Asian committee, which Asian Resuscitation Council, I think. Actually, that's the one which we are following. But the Indian Academy of Pediatrics, as of now, is following what the American Academy of the guidelines from the American Academy of Pediatrics.
Yeah, this NRP is entirely designed by AHP. Then another question from Professor Ramachandran: why preterm FiO2 21 to 30% and not 21%?
Sir, I think the reason is very simple. Most of us have been used to giving 60 to 100%. I mean, in fact, 100% oxygen for preterms. So it has become very difficult for people to take them away from the practice. That's number one reason. And the number two reason is in preterms or bradycardia, the evidence shows that if you use oxygen, definitely the time needed to increase the heart rate is much, much faster. And that is probably the reason why in the first place they were giving a high oxygen rate. So probably the idea would be, in case we have a child who is bradycardic, it should be fair enough to give a bit of oxygen, but otherwise I think 21% oxygen should be the standard, gold standard, whether it is preterms or terms.
This is from my own queries. Maybe Dr. Uma can answer to this. There are 3 questions. If there is no chances of survival, whether the resuscitation should be done or initiated, who will make the decision? Number 1. Number 2, good outcome, very unlikely, where the parents has the decision or the clinician has to make a decision to stop resuscitation. And if the good outcome is considered likely, what is the role of clinician in making a decision to stop the resuscitation or proceed the resuscitation?
All ethical questions do not have a right or wrong answer. So we have to go in a via media fashion. If we have adequate time, we need to counsel the parents in depth about like the pros and cons in a peri-viable baby or a baby who do not have any hope. If there is no hope or no purpose, we can counsel, and with accordance to the parents, we might kind of decide not to resuscitate at all. Say, for example, there is a severe congenital malformations and baby is more likely to die, and there is no hope or no purpose, then we could counsel accordingly. But if we do not know exactly, like whether if the prognosis is uncertain, and after counseling the parents, or if we do not have adequate time to come in terms with the parents, then we have to go for all-out resuscitation and decide at a later stage once we shift the baby to NICU to decide on. As such, like Indian guidelines do not support withdrawal or withholding life supports. So we do not have any laws or legal stand for us to unlike in abroad countries, UK or developed countries where there are definite guidelines for withholding or withdrawing support, Indian guidelines do not kind of, there is no specific guidelines or legal for us to, withhold. So everything should be in accordance to the parents. We should always try to get the parents with us. If both of us are, conflicting, say for example, a 28-weeker, if the parents are saying we do not want to resuscitate, we cannot go by the parents' will because they are 28-weeker. They are going to come wriggling and crying. So that is when we need to spend more time with the parents, do all the resuscitation, bring the baby to the unit, and then have a chat with them at a later stage.
Dr. Thiru, why the time frame has changed from 10 minutes to 20 minutes in the coming up? What is the reason behind it?
Okay, sir. This has to do with, again, with studies which have shown that there is even at 20 minutes, even if you have no heart rate, there is up to 10 to 15% chance of having a viable child. And some of them, I think about 3 to 5%, I cannot remember the exact number, but I think 3 to 5% having a normal neurological outcome, particularly with cooling. And that's probably the reason why they have made this recommendation about change, change from 10 to 20 minutes, sir.
So with this, I conclude my session, and thank you very much for the IAP Tamil Nadu and all the team, Dr. Balkrishnan, Dr. Vinod, Dr. Uma Maheshwari, Dr. Prakash, and our visionary Joint Secretary Thiru sir.
Thank you, sir. Thank you, sir.
For choosing this very important need of our program in the basic neonatology CME. Thank you once again. And I conclude this session. Over to Dr. Thiru.
Thank you, sir.
Thank you, sir.
Sir.
Thank you very much, sir.
One more question is there. Very important point to consider during resuscitation is to start passive cooling when we are at the point of drugs and cardiac compression. Who will take this question?
Sir, I would take it. Generally, we do not recommend passive cooling because the temperature can go erratic. So cooling has to be done in a very controlled situation. So we at this point we should not go. The temperature should not go up, or it should not become hyperthermic. That is one important aspect one has to take care. But what generally recommended is to bring the baby to the unit, assess the neurology. If the baby is fitting into moderate or severe encephalopathy, then to consider therapeutic hypothermia in a proper controlled environment rather than passive cooling. So there are so many studies where they did therapeutic hypothermia during transport where the temperature has been erratic and the outcomes have not been so good.
Thank you, Uma. Dr. Vinod, you can address this question. What should be the pressure used for suctioning?
So ideally 80 millimeters of mercury is the ideal suction pressure you are supposed to use. Anything between 80 to 100 can be used, but not more than hundreds.